Um, I'm now really pleased and honored to introduce our own colleague, Mike Royster. I feel like he's the power behind the scenes, a very quiet but stable and firm supporter of our coalition. He's been supporting us since its very inception, and he has a wealth of experience working to advance health equity in the Commonwealth of Virginia. Now, a little bit about him: he is the Senior Vice President at the Institute for Public Health Innovation, which provides expertise and oversight to an extensive portfolio of equity focused programs in addition to our coalition. Before he joined IPHI, Mike was the director of the VDH Office of Minority Health and Health Equity. He served as the director of the Crater Health District, headquartered over in Petersburg. And in these roles, he's overseen public health programs in both rural and urban areas. He's developed data tools to advance equity and led the expansion of community based efforts. Mike is board certified in public health and general preventative medicine and is a fellow of the American College of Preventative Medicine. So, Mike, welcome and thank you for all you've been to the coalition during its infancy year. So, here's Mike.
Thanks, Carolyn. And Rebecca, I hope everyone can hear me all right. I'm excited to have the opportunity to talk with you as part of this great conference on equity and immunizations. And so what I'll do during the talk is review some terms, as well as talk about and share some data. Some of it's similar, the same data really that Christy Gray shared earlier, so I won't spend too much time there looking at disparities and inequities. And then talking about some of the strategies that can be utilized and that are being utilized to advance equity and immunizations, in particular looking at COVID. So with that in mind, we can just review some terms that I think are really critical when we think about and talk about health equity. Hopefully most of you are familiar with these terms to some extent. The first that we talk about is a health disparity, which is really a general term that talks about differences in health outcomes or health access. And it doesn't really differentiate as to whether the difference in health outcomes is natural, whether it's socially produced, et cetera. And so the term health inequity, which is being utilized more often and many have probably heard, really helps to distinguish in more detail. It's not only a difference in health outcome, but it's a difference which is unnecessary and avoidable, and also considered to be unfair and unjust because it's tied to broader social conditions and processes in society that create differences in opportunities for people to be healthy and to have health opportunities. And therefore we see these differences and they're not natural. That's really what it comes down to, that they can be addressed and eliminated if we're intent about creating a fair and equitable society. And when we do that, then we're moving towards that ideal of health equity. And the CDC describes that as when all people have the opportunity to attain their full health potential, and no one's disadvantaged because of social position or socially determined circumstances. So it's really striving to achieve the optimal health for all, and recognizing that there are groups that have historically and in the present experienced any injustices and differential access to what allows all of us to be healthy, and that we have to pay particular attention to those populations and communities. And that really takes us to, again, this another distinction that's really important when we talk about health equity is equality versus equity. I know there's a lot of slides, graphics that kind of demonstrate the differences, and I felt like this one does a really good job. And briefly, what we see on the left is what would be thought of as equality. that there are three kids, each at a different level in the ground, which really represents kind of the historical and baseline inequities that they've experienced that have either put them at an advantage to be at the top or at a disadvantage to be in the lower level. And the fence represents current and ongoing inequities and barriers. And so what we see is inequality. When we focus on equality, each child would get the same box, one box to try to see over the fence, but it doesn't account either for the historical inequities or the current inequities that they face. Whereas equity recognizes both the history and the present context, and then provides resources, opportunities, and supports to address both of those so that everyone can have a fair outcome. And of course, some would say if you remove the fence altogether, then that gives everyone opportunity to achieve their full realization in self. And so we could certainly add that as another diagram as well. And so when we're talking about the either the height or the depth that they're standing in the fence, we're talking about factors that are often outside of individual control. And we think of those as those social determinants of health. And when we talk about equity, it's not enough to focus on social determinants, that is those factors of where people live, work, learn, and play. We also have to focus on how they're distributed among different populations, because those differences in access at the population level are what create health inequities in the first place. And so there's I really like to stress the two components of social determinants and their distribution in understanding inequities. So I'll very quickly go over data. Most, if not all, was also shared by Christy in her really informative presentation to help understand disparities and inequities. And oftentimes when we distinguish between disparities and inequities, we're saying that, inequities, because they're socially produced and unfair, we really want to focus our resources there. And that is very true in the example of COVID. And at the same time, we also want to address disparities, because one of our goals is to, reduce overall morbidity and mortality, as well as to give everyone or to help produce herd immunity. And so regardless if someone's socially disadvantaged or not, our goal is to get them vaccinated. And so Christy talked about the differences in age and how older groups are more likely to be vaccinated. Again, I won't go and spend much time here. She showed how when we look by race and ethnicity, that we've eliminated many of the inequities that exist by race and ethnicity, while we still see the Black population at a very low rate, similar to the white population. So again, an example of where, in this case, disparities and inequities, we want to address all of them, because we want to reduce morbidity and mortality overall, and to produce herd immunity for those folks who can't be vaccinated or don't develop an immune response. Looking at equity, you can also look geographically. And again, we can see here, as we're looking at COVID cases, where the rates are the highest in the state. And we see that they're highest in the Crater Health District area, including cities of Petersburg and Hopewell. We see far Southwest Virginia, which is a very rural area, as many know. Some areas in Central and Northwest Virginia, as well as part of the Northern Neck. And also, if you look closely, you see many of the cities in both urban and rural areas, Danville, Galax, et cetera, are places where there's an increased rate of COVID cases as well. So looking at data from this standpoint also helps us to identify disparities and inequities and to focus our efforts. This slide, to me, is really representative of understanding just the full scope of inequities that we see in our society by race and ethnicity. That, this data is a little old, but I'm sure if we looked at mortality rates from COVID by race and ethnicity today, we would see a similar trend, that Hispanic and Black residents of Virginia have dramatically higher rates of mortality from COVID that really can be traced back to historic inequities around racial segregation, underfunding of Black and brown communities and educational opportunities, job discrimination, et cetera, that has led to a disproportionate presence of Black and Latinos in essential jobs that are low paying and that can't be done remotely, compounded by the fact that those same historic and present day inequities have led to higher rates of chronic disease, which then place people at higher risk for complications from COVID, and then adding on the access and historical trust issues of the healthcare system that can then further exacerbate the inequities. And so the causes are really important to think about, and many people talk about, how do we address the vaccine inequities? And we see that there's a lot of conversation around, is it vaccine hesitancy or is it vaccine barriers? And I think this is an example of where it's both and. We see hesitancy and we see barriers, and we have to understand why they exist to address them. So I'm just going to show a few quotes that kind of give an idea of what some of the hesitancy issues may be in communities of color, as well as the barriers. And so we see here from some focus groups that were completed, a African-American respondent saying that, why are you so concerned with us now? Where were you when we needed help with type 2 diabetes, heart disease, access to care? So that distrust of a system that has allowed inequities to exist for generations and suddenly now is interested. And so the distrust and the questioning that comes out there. And another perspective of a community health worker referring to experiences, or the concerns of going to seek information or to get vaccinated, and whether ICE or immunization or immigration and customs enforcement will be there looking for people who may not have documentation. And in addition to that, we know just from what many of us seen in the media, as well as our experiences, that there have been significant access barriers as well for many communities that have been marginalized because of socioeconomic inequities and other structural barriers. And so there's a combination of factors that have played into this. So as we think about what are some of the strategies that we can utilize to address these inequities, I will say that there are many evidence-based strategies around improving immunization rates in general that we certainly need to keep in mind and to integrate into our approaches. The recommendations from places like the Community Guide for Preventive Services, the U.S. Preventive Services Task Force, CDC, American Academy of Pediatrics, and others all put out evidence-based recommendations, which we don't have time to go into now, but which focus on things like provider and system-based interventions, increasing community demand for vaccinations, and enhancing access to vaccination services. And so while these standard practices are important, without an explicit commitment to equity, they can actually worsen inequities in immunization rates, as we've seen throughout much of the COVID pandemic. So what are some of the strategies that are being utilized to promote equity in COVID vaccine? Let's walk through just a few examples that I pulled for this presentation. And so if we think about younger populations, as vaccine is now being approved for 12 to 17-year-olds, we have the chance now to incorporate equity intentionally into efforts to reach this audience. And so Families USA has identified several state-level actions to ensure equitable distribution for young people. And many of these can be replicated locally as well. But for youth, they focus on vaccine availability, consent, information needs, and external motivators. And some of the key points that they talk about are working with youth serving organizations as vaccine locations so that it's easy access and availability for youth, reaching youth through their caregivers, recognizing that the decisions ultimately are made by their guardians, and so not only educating them, but also educating their parents and other caregivers. Uh, Obviously, social media is a really critical aspect of the approach to young uh, young folks. And the last presentation really gave some great insights into some of the social media strategies, as well as focusing on trusted messengers, people that young people respect, who are oftentimes other young people. And what some of the studies show is that if on social media, young people who really share a common understanding of the challenges that COVID has caused and concerns about the vaccine, they can be really effective in influencing others to consider getting the vaccine. And then there's incentives that can be included as well. I'll also look at some other populations. Again, Unidos US outlines their strategies that they use for outreach to Latino families, again, by building trust, meeting people where they are, engaging trusted voices. And they have a great resource. The link here on the website talks about a lot of the work that they're doing to reach Latino communities. Another great resource is community health workers. Regardless of the population, community health workers can be a critical part of the strategy. And so they're natural leaders from communities who are provided training and support to conduct outreach, provide education, navigate to services, and advocate on behalf of their clients. As was mentioned at the beginning by Carolyn, ImmunizeVA has developed a curriculum to disseminate training to community health workers and lay health promoters to educate their neighbors and to engage them. And so this is considered to be a really critical effort. And the federal government has actually poured millions of dollars into communities to help expand the number of community health workers for COVID response. In the interest of time, I know we're going to be running a little short. I'll kind of briefly just mention and flash through the last few slides to reinforce the importance. I talked about data, and disaggregating data is always critical so that we can understand who's at high risk and who we need to target our efforts to reach. And then there's a few overarching principles that I would just briefly mention that we could have a long discussion on by themselves. That cultural humility is a critical part of how we engage with communities so that we can build that trust and relationships. Implicit bias is an issue that we know we've had much realization of its impact on interactions. And so in our work, we really encourage people to take the Harvard Implicit Association test and learn about the strategies that can be used to address implicit bias on the individual and organizational level. And then also conducting equity impact reviews, because there's always the potential for unintended consequences from our policies and decisions. And even good intention, as we've seen around vaccine clinics in communities of color, oftentimes don't work out right if we haven't thought about the unintended impacts and haven't engaged the community in helping to develop the strategies. So with that, those are some of the hopefully useful ways that you can think about how to promote equity in communities across Virginia as we really try to ensure everyone is vaccinated. Thank you.
Wow. Well, thank you so much, Mike. This has been such a wealth of information. I know that our work groups have begun discussing strategies for eliminating inequities in vaccine access and distribution. So this has given us a lot to think about. I wish we had more time to discuss. Carolyn, did you have anything as we wrap up that you'd like to add?
Well, I think Mike, at least for me personally, has really, at the beginning of my chairpersonship, really opened my eyes with the whole equity lens, and I've tried to start implementing that in the teaching of pediatric residents down in Eastern Virginia here. So, Mike, your impact is is like a pebble in the pond. We've got circles of influence from you coming out to new pediatricians being trained. So I personally want to thank you for that education.
Thanks, Carolyn.
Well, I can't echo Carolyn's sentiments enough, and I'm seeing a lot of thank yous in the chat. Others are appreciative, and if you do have questions, please feel free to enter them in the chat, and we will try to get back to you. But in the moment, we're going to pause the broadcast again and come back with our final presentation, an award for outstanding advocacy. So just hang tight for one moment, and we will be right back.